Hello everyone, my name is Jagan Dinadayalan. I'm a clinical application specialist working for Hamilton Medical. So this presentation is about personalization of NIV support in acute hypoxemic respiratory failure or de novo hypoxemic respiratory failure. So this is basically review of a paper that was released 2023 by Dr. Domenico, Dr. Lavina and Dr. Lissi. Because this paper summarizes the most recent evidences to strategize NIV support for acute hypoxemic respiratory failure patients. So what is de novo? De novo came from a Latin word which means from the new. To be in particular, de means from and whereas novo means new. So in our case, something that is present for the first time, for example, hypoxemic respiratory failure present for the first time, can be considered as de novo hypoxemic respiratory failure. So far there are no standardized NIV strategies that need to be followed in terms of ventilating a patient with acute hypoxemic respiratory failure. So in patients with the de novo hypoxemic respiratory failure, European Respiratory Society and American Thoracic Society makes no clear recommendation regarding use of NIV. So de novo hypoxemia can be defined as severe hypoxemia with tachypnea, the other signs of respiratory distresses in the absence of chronic lung disease such as COPD. So in this presentations, what are the contents we are going to cover is physiological rationale behind acute hypoxemic respiratory failure, and what is patient self-inflicted lung injury, and what are the clinical evidences, physiological based strategies for NIV support, and identifying treatment failure, and then we're going to wrap up with the summary. Physiological rationale. Using NIV support for acute hypoxemic respiratory failure, we have seen major changes during the last decade due to the COVID pandemic. And using NIV prevents intubation and complication associated with the intubation. It also avoids sedation, paralyzing agents so that patient can cough, clear secretions, swallow, communicate. So with this lot of positive effects, but it had been noted that 30 to 60% of patients leads to failure on NIV, which increases the mortality rate. So how does it fail? As per the evidences, allowing the patient to breathe spontaneously with the existing lung injury can increase the rate of intubation and leads to failure, which increases the mortality rate. So ARDS is a subset of acute hypoxemic respiratory failure. So the severity of the hypoxemia can be considered into three different categories, depends on the PF ratio. So ARDS and AHRF appear to belong to the same disease spectrum with the lung injury, hypoxemia, altered lung mechanics, and the alveolar dead space fraction. So it is essential that to understand the physiology of the spontaneous breathing before strategizing the NIV for the acute hypoxemic respiratory failure patients. Looking at the positive effects of spontaneous efforts, it maintains end expiratory lung volume and improves transpulmonary pressure, better gas exchange, predominantly better dorsal ventilation, and lung aeration to the dependent part of the lung will be better and reduces VQ mismatch since spontaneous breathing done by respiratory muscles, the primary muscle that is involved in generating the force is the diaphragm. So prevention of diaphragmatic dysfunction is most important. As the main expiratory muscle, the diaphragm contributes 72% of the tidal breath. When the spontaneous effort starts, diaphragmatic fibers develops tension and shortens. Firstly, it expands the thoracic cavity and pleural pressure falls and lung volume increases. Secondly, it produces increase in the abdominal pressure and pushes ventral wall of the abdomen outward. So this pressure generating capacity of the diaphragm can be determined by several factors, but mainly two different factors: force length relationship. So when there is an increase in end expiratory lung volume, which will decrease phrenic nerve stimulation and negative swings of the pleural pressure. So better the end expiratory lung volume, so reduction in the intensity of the spontaneous effort. The second one is the radius of curvature of the diaphragm. So as per the Laplace law, pressure that is being generated is equal to the tension by radius. So the diaphragm is a curved surface, so the pressure difference across it is proportional to the muscle tension and inversely proportional to the radius of curvature. If the diaphragm becomes flat and increases the radius, the pressure generating capacity of the diaphragm drops. In this comparative study, when the spontaneous breathing during mechanical ventilation is diminished due to neuromuscular blocking agent, the negative swings of the esophageal pressure is decreasing. As a result, inspiratory transpulmonary pressure decreases. So note that the inspiratory transpulmonary pressure linearly correlates with the intensity of the spontaneous breathing effort. In the case of normal lung, the generated negative swings of the pleural pressure evenly distributed around the lung surface during the inspiration, representing fluid or liquid-like behavior. But in the injured lung, it's not uniformly distributed across the lung surface, but rather it is concentrated on the dependent part of the lung regions, causes heterogeneous ventilation. So this locally elevated pleural pressure causes unsuspected local overstretch in the dependent lung regions. Also, air shift from the non-dependent to the dependent part of the lungs during initial phase of inspiration, which we call it as a pendulum effect. When we look at the mild to moderate ARDS or acute hypoxemic respiratory failure, the spontaneous efforts as much more gentle contraction, sustainment of transpulmonary pressure, improved end expiratory lung volume, homogeneous ventilation, and so spontaneous efforts are not much intensified, but rather it is modest, not a high of pleural pressure swings, maintains relatively low plateau pressure, not a high of airway pressure gradients. But considering moderate to severe ARDS, do we allow the patient to breathe spontaneously? No. We have to consider something called as a PCD. So this PCD is a patient self-inflicted lung injury, is a life-threatening condition arising from excessive respiratory effort and workout breathing in the presence of severe lung injury. In this CT scan of end expiration demonstrates that aerated lung is non-dependent while the dependent lung is collapsed. So when we look at the end of inspiration, during a spontaneous breath, there is a little change in the non-dependent part of the lung, but dependent lung, which was previously collapsed, is now partially tidal recruited. Also, the negative swings of the regional pleural pressure is twofold higher than the global esophageal pressure. So, which indicating that greater distancing pressure is applied to the regional lung near to the diaphragm compared to the pressure transmitted around the lung region. To understand the pendulum effect clearly, so it is the exchange of air from one lung region to another without causing a significant change in overall tidal volume. So in this spontaneously breathing patient, note that early inflation of dependent lung region, which is zone 3 and zone 4, was accompanied by deflation of non-dependent lung regions, which is zone 1 and zone 2, indicating movement of air from non-dependent to the dependent part of the lung, which is called without any changes in the significant tidal volume. So which we call it as a pendulum effect. So in the graph as well, we can notice that zone 1, zone 2, zone 3, zone 4. So zone 3, zone 4, in the initial phase, it had been taken air from the non-dependent part of the lung. So in this comparison of paralyzed versus spontaneous efforts on mechanical ventilation with the EAT images, we can see that paralyzed patient has no pendulum compared to spontaneous efforts with the lung injury. So not only the pendulum effect, also there is an increased perfusion can be noted when we compare with mechanical breath versus spontaneous breaths. So pulmonary blood vessels are compressed during positive pressure mechanical breath, causing vascular pressures to drop. But when the spontaneous efforts are added, the transpulmonary pressure increases, thereby increasing tidal volume and also causes further lung injury. So higher negative pleural pressure swings distance the pulmonary blood vessels and also increases the perfusion, which causes the transvascular pressures to increase, causing fluids might enter into the interstitium of the lung. So bottom line, allowing the patient to breathe spontaneously in the presence of lung injury, so which will induce increased effort and as well as pendulum effect, as we have seen, and also increased vascular pressure, ultimately lead to patient self-inflicted lung injury. So let's look at the clinical evidences. So which is effective method to treat acute hypoxemic respiratory failure non-invasively? Is it HFNC, CPAP, pressure support NIV, or helmet or mask? So there are plenty of papers and researches being done and being published around the year. So let's look at one by one. What do they say? So in this paper, which was published in 2020, says that face mask NIV and CPAP may reduce intubation in low severity acute hypoxemic respiratory failure and lower the risk of death. So this is another paper which was published in 2015, suggesting that high flow oxygen through nasal cannula in acute hypoxemic respiratory failure, suggesting that higher risk of intubation and mortality in severely ill patients treated with NIV compared with HFNC. So in this multiple randomized controlled trials released in 2020, 2021, 22 shows that high flow nasal cannula reduces need for intubation but not the mortality rate. So this paper released 2022 on COVID patients. So on the effect of CPAP. So CPAP significantly reduced the risk of tracheal intubation. So this paper, which was published in 2016, shows that effect of non-invasive ventilation delivered by helmet versus face mask is helmet NIV resulted in a significant reduction of intubation rates compared to the face mask NIV ventilation for acute hypoxemic respiratory failure. So what is the mechanism behind this effectiveness of helmet non-invasive ventilation? The reason is because it can provide effective administration of higher PEEP levels, more than 10 centimeter of water, and improves oxygenation and reduces the risk of PCD by inspiratory effort modulation due to the improvement in the end expiratory lung volume and also more homogeneous lung inflation. So in this comparative study, which was published in 2021, shows that comparing helmet NIV versus high flow nasal ventilation for COVID-19 patients shows the rate of endotracheal intubation was significantly lower in helmet group. When the larger trial of comparison done with conventional NIV method versus helmet NIV, and it had been noticed that helmet non-invasive ventilation did not significantly reduce the 28 days mortality rate compared with usual respiratory support among patients with the COVID-19. So it is also important to note that effect of flow on PEEP during HFNC. So this paper was released in 2011 shows that there seemed to be a positive linear relationship between the flow and the airway pressure. So every 10 liters of flow can increase the amount of PEEP that is being delivered to the patient by HFNC method. So coming to the bottom line, so these data which we have seen highlights that uncertainty about the optimal initial strategy for NIV in acute hypoxemic respiratory failure patients. Due to its simplicity and reduction in the rate of intubation compared to the standard oxygen therapy, HFNC represents the initial treatment of acute hypoxemic respiratory failure by the clinical guidelines. And the higher PEEP delivered through the helmet interfaces represents most promising alternative strategy as well. But as always, ongoing clinical trials are evaluating this approach. Physiologically based patient targeted strategies. So important factors that needs to be noticed that a one size fits all approach is likely not beneficial in acute hypoxemic respiratory failure. and delayed intubation after prolonged exposure of spontaneous breathing may be associated with the worse outcome and failure. And considering individualized treatment for acute hypoxemic respiratory failure, we need the right tools to assess the risk of patient self-inflicted lung injury, and also to identify the earlier identification of NIV failure at the bedside. Also, recent data indicate that phenotyping the patients based on the intensity of the inspiratory effort may provide better clinical decision. So according to the studies that we have seen so far, which shows that the physiological study of acute hypoxemic respiratory failure with the patients of less than 200 mmHg of PF ratio showed that high PEEP helmet NIV and CPAP are both capable of improving oxygenation compared to HFNC, and NIV decreases inspiratory effort but increases transpulmonary driving pressure, especially for the patients with low inspiratory efforts. And CPAP does not increase inspiratory effort or pulmonary driving pressure. And another NIV trial showed that helmet NIV seemed to reduce the rate of endotracheal intubation and improve the survival rate as compared to HFNC in the patients with PaCO2 of less than 35 mmHg. So it is important to note that the helmet NIV had no effect on normocapnic patients who had a PaCO2 of 35 to 45 mmHg, and this data suggests that the patient with the higher efforts with a high tidal volume and high minute volume and less PaCO2 range may benefit from non-invasive ventilation. With the decreased effort, spontaneous effort and normocapnia patient can be better with the HFNC or CPAP with the face mask or helmet. And if the patient is normocapnic, increased effort may benefit from non-invasive ventilation. So it is important point is that assessing the inspiratory effort at the bedside are mandatory to allow us to optimize the use of non-invasive techniques for respiratory support. Identifying the treatment failure. So how can we predict failure? So lack of improvement in gas exchange, persistent signs of respiratory distress and increased work or breathing like tachypnea or dyspnea should indicate the need for endotracheal intubation. Also, there might be a sign high risk of PCD. And when we apply the PEEP initially, the initial improvement in the oxygenation should not be seen as the conclusive sign of treatment success, as it may be a false reassuring. So another indicator called ROX index was defined as the ratio of saturation by FiO2 to the respiratory rate per minute. So it has been shown that the ROX index is being a better predictor for HFNC failure. Looking at this survival proportion graph of ROX index versus the intubation rate, when there is a ROX index less than 3.85 after 12 hours of HFNC treatment, and further worsening of ROX index over time have been associated with the increased rate of intubation percentage. So when we look at this graph, delayed intubation and associated risk of death in the hospital. So earlier identification of failure and intubating a patient will save the life of the patient, because the delaying of identification of NIV failure will increase the risk of death in the hospital. Even though there is a less validated tools to identify treatment failure on CPAP, but recently ROX index seemed to show if it is less than 6 within 24 hours of CPAP shows excellent accuracy in predicting treatment failure. So during non-invasive ventilation, NIV failure, if it is tidal volume is more than 9.5 ml per kg of predicted body weight and persistently higher efforts are parameters strongly associated to subsequent failure. And also, unfortunately, there is some limitations like tidal volume measurements may be difficult in the presence of leak during face mask NIV and is impossible with the conventional tools during helmet support. And also similarly, the inspiratory effort assessment currently requires esophageal pressure manometry, which is not always feasible in non-invasive ventilated patients. Studies to identify inspiratory effort non-invasively are ongoing. So right now we have a ACOR, which is heart rate, acidosis, consciousness, oxygenation, and respiratory rate, has been shown to accurately identify the patients who are prone towards the NIV failure in hypoxemic patients. So the ACOR score in patients with the NIV failure and the success from the initiation to the 24 hours, and the pink one with the ACOR score, lower the ACOR score, the success rate, and the higher the ACOR score, the blue line shows with the failure rate. So with this QR code, you can get the ACOR calculator directly. So the failure rate depends on the time and updated ACOR score for predicting the failure of non-invasive ventilation. So by the time increases and the ACOR score also increases, is the higher chances, higher percentage of the failure rate. So far we have seen multiple evidences and guidelines how do we strategize the non-invasive ventilation in acute hypoxemic respiratory failure. Let's look at the initial management and monitoring of the patients with the de novo acute hypoxemic respiratory failure. Initial management of patients with a PF ratio of more than 150 mmHg can begin with HFNC. Maximum tolerated flows can be given. Target up to 60 liters per minute. So the temperature have to be maintained to optimize the patient comfort. So strict clinical monitoring to be done. So ROX index of during HFNC, if it is below 3.85 after 12 hours of treatment, is strongly associated with the treatment failure in non-COVID patients. But if it is in COVID patients during HFNC, ROX index shows more than 5.35 after 4 hours of treatment is associated with the success. To initiate a therapy for a patient who has a PF ratio of less than 150 mmHg and low effort, so this low effort of the patient can be indirectly estimated by increased of PaCO2 range if it is more than 35 mmHg in the absence of metabolic acidosis, can be initiated with the high flow nasal oxygen with the maximum flows and prone position, or can go for CPAP, better with the helmet with the higher PEEP. So again, the strict clinical monitoring have to be followed. In non-COVID patients during high flow nasal oxygen, ROX index less than 4 after 6 to 12 hours of treatment is a predictor of failure. So if it is a COVID patient, high flow oxygen ROX index more than 5.37 after 4 hours of treatment is a strong predictor of success. And if the patient initiated with the CPAP, ROX index of less than 6.64 after 24 hours of treatment is the accurate predictor of the failure. Coming to the patient with a PF ratio of less than 150 mmHg with the high effort, this high effort can be indirectly estimated with the lesser PaCO2 and the absence of metabolic acidosis, can be initiated with the pressure support ventilation. Better with the helmet, but not limited to helmet, can be used with the face mask as well. Again, the strict clinical monitoring needs to be followed. So if the patient initiated with the face mask pressure support NIV, the tidal volume more than 9.5 ml per kg of ideal body weight is a strong predictor of failure, and the ACOR scale more than 6 to 7 strong predictor of failure. And lack of reduction in the esophageal pressure inspiratory swing after 2 hours of treatment is the strongest predictor of failure. Vast dyspnea is more than 4 independently associated to treatment failure and mortality rate. And persistently high esophageal pressure inspiratory swings are associated to failure. If the patient is initiated with the helmet pressure support, esophageal pressure inspiratory swings more than 10 centimeter of water and transpulmonary driving pressure is more than 20 centimeter of water, is after 1 hour after treatment start associated to treatment failure. Vast dyspnea more than 4 before treatment start independently associated to treatment failure. To summarize, esophageal monitoring is becoming crucial in spontaneously breathing patients to identify strong inspiratory efforts. So early detection of NIV failure is most essential to lower the mortality rates, and personalizing NIV support based on the patient inspiratory effort and PCL will yield a better outcome. Thank you for your attention and for watching this video.